Hi, James.
Hello, how you doing?
I'm good, thanks. How are you?
Doing well. I'm in a vehicle right now trying to park.
Okay. Focus on that.
Indeed. So this is the right time, correct?
Yes, we're a minute early still, but yes, this is the right time.
Well, when you say a minute early, years ago I used to be in the army, and if you weren't 15 minutes early, then you were late.
It's a good mindset.
It
I
has
keep
been
up.
it's been difficult to shake certain I don't know, certain things that I picked up back then, habits.
Hi, Keela. It's still on
How are
mute.
you?
Oh, there you go. There's Jeff. Good.
Hey, Jeff. Are you feeling better?
I am, thanks. Yeah, I still have a little bit of a scratchy throat and cough, but
Sounds like you were down for the count.
yeah, I mean, I'm still testing positive, now like whatever
Oh,
it is,
bummer.
12 days later, but yeah.
Yikes. Yikes. I coach
Oh,
high school volleyball and I had my first kid already test positive. So, but they've, it's a little unclear, like what is the policy these days? How are we doing this? So the school policy is five days out and then 5 days with a mask,
yeah.
regardless of testing. It doesn't matter,
Hmm.
Yep.
which is a little strange, but
Yeah, that's the official CDC guidance at this point. So
yeah. Yeah.
I was talking to my doctor about because my wife and my daughter haven't had it. So she was like, as long as you're testing positive, you're technically could still spread it to them. So, up to you what you want to do. You can go outside, you can go around in a mask, but so I'm still sequestered.
Yes.
Hopefully for not too much longer. That line's getting very faint.
Well, and now at least we can like home test and keep an eye on it.
Oh yeah, I remember back in the day when like you couldn't get tests and like
Yep. All right. Hey, Mike, how's it going? Haven't talked to you in a while.
It's been a bit. Hello, I'm well. How are you?
Good. Okay, I see we're getting a couple more people, so we'll get started in just a minute here. Mike, do you know if we're expecting Sir Ken?
He's here. He had a bad link for a minute, but we were able to help him.
Here
Yeah,
you are.
I had that bad link as well. I don't know why that's the
You
case.
did. I'm sorry. Yeah, it's a little confusing because we have two different links for our two different monthly meetings. Hi there, Ken.
Hello, good morning. It's a
How
great
are
day.
you? It is a great day. It is an excellent day. All right. I think we'll give it one more minute and get started.
I just go here. I'm dropping in the chat the link to the Hyperledger Labs like events page. I just go there and then click on September and click on today, because that way if anybody changes the link, I assume they'll update that. So
That is a great link to have, Steve. You're right. Okay. So let's go ahead and get started. We've had a couple of weeks off because of the August sort of break that we took. So let me just share my screen. We'll get through our housekeeping items and then we'll be able to jump into our presentation for today. So you should be looking at our Cardea screen here. So these are this week's meeting notes. I'll keep them updated as we're going through today's presentation. If anybody wants to make updates or corrections, you can either let me know or you also can make them on the system. So just as a reminder, First of all, welcome to today's Cardea meeting. It is the 14th of September. We're very pleased to have some guest speakers today. But before we get there, just a quick reminder that we are covered by the Linux Foundation antitrust policy. You can find that in our meeting notes here, as well as on the Linux Foundation website. We also are covered by the Hyperledger Code of Conduct. And in summary, everybody is encouraged to have a voice here, to be nice to each other, and to encourage participation from everybody. We want everyone's voice to be heard. And if you have any concerns with either of these policies or the actions happening here at this committee, you can reach out to Ken or myself as co-chairs. So just let us know, and we're happy to follow up on that. But there are also official channels through Hyperledger. Excellent. So I think, Ken, unless you have anything to add to our welcoming here, we can get into today's agenda.
Happy to just get started.
Excellent. Okay, so today I'll update our attendees as we go here, but today we have some special guests coming to present about the work they're doing in the space of patient access to health data and the tools and solutions that they've been implementing in terms of being able to broker some of that health data exchange in their space. So we're very excited to welcome both Glenn Keat and Jeff Grant from Invitae/Citizen.
I'll explain that.
Yes, and I'll let you guys do your introduction since you'll probably do it a little better.
Okay, let me see if I can take the screen here. I have a presentation. On the wrong page. There we go. I think I lost my file that I was looking at here. There we go. Can you guys see that?
We are with you, yes.
Perfect. I'll put it in presentation mode. So to start, I'm Glenn Keat. I've been working in what's known as health information exchange for almost 30 years now, and healthcare information technology for longer than that, without giving away my age. I currently work for a company called Invitae. I got there through their acquisition of Citizen. And so Citizen is basically a wholly owned subsidiary of Invitae, and we've carried on our mission and goal at Citizen after the acquisition in 2021 by Invitae. Invitae is a genetic testing company. It's a clinically ordered genetic testing company, so it's not like 23andMe. A physician has to place an order for you, and it's typically for people who are diagnosed with cancer or a number of other things. They also have areas where they do childbearing types of genetic tests, matching with family members and other items. And then I'll tell you much more about Citizen, but I'll let Jeff introduce himself first.
Sure. I'm Jeff Grant. I've also been in the HIE space for a long time, about a little over 20 years now. Got started back in the day at Axolotl as like a tech support guy, and Glenn was my boss. So we've been working together on and off through, I don't know how many companies now, many. But yeah, also came over as part of the Citizen acquisition. And previous to that, the Citizen acquisition of Stella. So kind of been through a few of these but yeah, excited to keep carrying on with the Citizen mission under Invitae now.
Thanks, Jeff. Yeah, I can't shake Jeff. So what do we do at Citizen? So Citizen had a focus on two major diagnosis areas: patients with cancer and patients with some form of epilepsy, rare neurological disorders. And we utilize the tools that we have in the communities we build to connect patients with second opinions, to clinical trials, and so on. In order to be able to do that, we need detailed research grade medical records of those patients. And so we set about building tools to be able to gather those records for those kinds of patients. Let me see if I can move this. Once we do that, we provide the patient with a set of their medical records that they have easy access to too. And so a founding principle of Citizen is that we provide patients with their own medical records and the abilities to do things with that. The founding story for Citizen is that our founder, Anil Sethi, sister was diagnosed in 2017 with metastatic stage 4 breast cancer. And at the time, he was the director of health at Apple. He had a lot of connections. He had been in the space a long time. So he, as it says, crisscrossed the country with his sister looking for ways to extend her life. Johns Hopkins had said she had 2 weeks to live. And so he thought that he could use his connections and do a lot of stuff to make sure that, her life was extended. And it was extended. She lived about 6 months after that. But as part of that, he learned some things. One, that we leave a breadcrumb of medical records everywhere, particularly the very sick. And gathering those and having the full power of all of those could have helped to extend her life further. So he promised his sister that he wasn't going to retire, sit on a beach. He was going to dedicate the rest of his career to trying to solve the problems, which is essentially to be able to get patients full access to their medical records so they can then easily be matched to clinical trials or to see and get a second opinion from another oncologist and the like. So that's why Citizen exists. So I'm going to take you through, this is what I started taking you through was our normal slide deck. I'm taking a pause because I don't expect, other than Keela, that people really understand what HIEs are. And we make great use out of HIEs, or health information exchanges. So what is an HIE and why? So it stands for Health Information Exchange. Most typically, not 100% of the time, it's a not-for-profit organization that has taken on the technical infrastructure and tasks, plus the governance responsibilities of gathering and sharing medical records with authorized providers. Their missions are usually just to improve the health outcomes of the region that they work in, as well as to reduce the overall expense of all the participants by making the data liquid so that it can be shared amongst people with different platforms, different EHRs in different institutions. So by virtue of that, almost always the HIE is a neutral third-party organization sitting amongst oftentimes competing health systems and lab systems and providers and the like. In most cases, HIEs were formed to serve providers, the physicians and the health systems and such, and were not configured to serve patients. That was a bridge too far for most of them, because that requires, in many cases, could require an army of people to be able to deal with that couple order of magnitude greater number of participants than you would have if it's just the physicians in your region that are doing that. Lastly, currently, I think the number's gone up. There's about 280 million Americans with their data held in an HIE somewhere in the country. These are the HIEs in the US as of, I put this together in like March. The trend is that there's getting to be fewer and fewer because there's consolidation that's happening. But as you can see, there's a fair number. I didn't go and count, but there's about 80 or 90 HIEs across the country. Some of them are statewide HIEs, like Big Sky Care Connect deals with the entire state of Montana. And as far as I know, it's the only HIE in Montana. Whereas California, you can see that there's, almost a dozen. There's some dominant ones like Manifest MedX, which is notionally a statewide exchange. And then there's some small ones like the Santa Cruz HIE. I like to call them out because that's the first and longest running HIE in the country, and one that Jeff and I helped to basically establish many years ago. Bronx Rio right here, Keela does a lot of work with them. So they're one of 7 HIEs in the state of New York. Anyway, so before I jump back, any questions on health information exchange, HIEs, why, how, whatever?
I think I would add one point of context, which is that they're not all created equally, right? And so they do offer different service packages in their, as their day-to-day operations. Some of them are simply like using Florida as an example. Florida is strictly sort of a hospitalization routing, a notification solution, whereas other HIEs are actually data warehousing and doing analytics and data aggregation and things like that. So they having the title of HIE does not mean that they offer the same services universally. And there are certainly some that are more advanced. As Glenn mentioned, Santa Cruz HIE is one, that I would call out as well as being super advanced in their integration of healthcare tangential data as well, like social determinants and community data to their health platform as well. So just pointing that out. Not
Yeah,
all are the same.
I think that's great. Yeah, it's true. And I think that, one thing that we really should call is there's different participants in each. You almost always have doctors in one form or another from physician offices, but some of them have a really heavy payer presence. Some of them have no payer presence. Some of them have lots of other things, like Santa Cruz just rolled out a thing about a year ago where they have, ambulance data in there now. So EMTs who are in ambulances are part of the healthcare exchange and adding data and retrieving data too. So lots of them with lots of different types of participants coming in.
As long as we're saying that, they also have a variety of business models. These are, as I said, they're generally not for profit organizations, but of course it requires money to run infrastructure and do the connections and so on. And they didn't all set up in the same way. Some get statewide money from their Medicaid places. Others get and collect dues from the providers who participate. And then there's plenty of things in between. The ones that have managed to get payers to participate are, able to get that. Obviously, they're the deepest of pockets, and those are the ones that can get some of the most benefit by having reduced quantities of, imaging done, because the providers can see an image that was done 2 weeks ago at another facility if there's an HIE. So anyway, just that. If you've seen one HIE, you've seen one HIE. They're kind of like snowflakes.
Your map indicates some states that don't have any coverage, like New Hampshire and Illinois, and some of the institutions may or may not cover all the participants in their state. So it's not creamy peanut butter; it's more like chunky with some gaps. Is that an accurate assessment?
That's a very accurate assessment. There's consolidation going on. So as I said, 5 years from now, this map will have far fewer names on it. The thing I hadn't mentioned also is that there are nationwide networks for health information exchange. So there's for example, a thing called Care Quality, and you can be a participant on Care Quality for a treatment use case. So under HIPAA, there's treatment, payment, and operations that allow you to share personal health information with other providers. And under that use case, any provider that's connected can query for a patient with data anywhere within the network and get it back. Now, that's typically tied to institutions and other things that are not necessarily HIEs. More and more, we're seeing HIEs are connecting to those things. So we're going to see the land shift. But the point I'm making is that the gaps you see in Illinois and such are not actually fully gapped because there are ways to get information for those patients. And then there's another movement, which is to get, patient access across these networks. And I'll talk a little bit more about that. So anyway, normally when I'm talking to HIEs, I don't bother explaining HIEs to them. They know what I'm doing, what they're doing. So what is our goal at Citizen? We basically are championing the rights of patients. We want them to be able to get their medical records. They actually have legally the rights to them. First, HIPAA provided them the right, going back starting in 1996, that they can ask for their records. And then starting in 2016, but not really starting to be enforced until 2021, was the 21st Century Cures Act. And that Cures Act strengthened those provisions and, in fact, put some teeth into people that were non-compliant with providing patients their records. We took the position, and HIEs are just as subject to this as anyone else. The Office of National Coordinator made that perfectly clear, that HIEs must also respond to patient requests for medical records. The kind of little known secret is that, of course, most patients don't know about HIEs, so they don't know to ask the HIE for the patients, but that's slowly changing. Anyway, our position is that HIEs are the best place for patients to get their medical records, and that's because they're already gathering, organizing, doing some processing on that data, including, patient identification / matching of that patient across institutions and the like. And our goal was to find a way where patients could, in a self-service way, get their own records from those HIEs without burdening the HIEs. As I mentioned early on, the HIEs do not really have the wherewithal to be able to support a patient-facing operation. So our solution was called the Cures Gateway, named that way for the 21st Century Cures Act. As it says here, I won't read all this, but it's a self-service solution for patients to be able to remotely request and get their own patient information, their medical records from these sources. So the first thing that will be obvious is that how do you know that that patient sitting at the end of a computer requesting their records is in fact that patient? So there's a standard, I don't know if I'm speaking out of school, but NIST IAL2. Anybody heard of that?
Yes.
Well, I know you did. I don't know if that's a focus in this group, but the IAL2 is a way that you can be reasonably assured that the person has been identity proofed, has provided a government ID of some form, it's been matched, it's been proven to be a true ID. They bind the user to that ID through liveness and photo matching and so on and so forth. So part of our solution requires that the patient is identity proof to NIST level 2. And then we utilize standard protocols that HIEs are used to using already for sharing data with and without each other across with health systems and providers and so on. So we don't require them to do anything new. We're utilizing the same protocols. As I said, we ensure that the patients are identity proofed. And then we allow those HIEs to have the providers there who are being asked to give medical records to patients to direct it back to the HIE to take that over. Any questions before I go on? Okay. I won't go into too much detail on this, but when a patient asks for their records, there's only about 2% of the patients nationwide that actually have and use a personal health app. So what are they going to get their records into? So Citizen provides a free one. That's the center one here. If the patient wants to request their records and wants to have them in a tool that they can do stuff with, we provide that free of charge to the patient. And if they happen to have cancer or a rare neurological disease, we provide them with additional services. If the patient is one of the 2% that already have a PHA, we connect third-party personal health apps with our gateway. They need to apply. They need to be vetted such that we know they're not a Trojan horse application. But if they have a valid personal health app and it does identity proofing to NIST level 2, they can connect to the gateway and utilize our network. And that's free of charge to that PHA. It's always free of charge to the patient. And then the third way is if the patient doesn't have a PHA and isn't really interested in going down that route, we allow them to simply download a PDF of all of their records. I don't think I'll go too much into this, but we sit in the middle, in between HIEs and those personal health apps, and we allow the secure exchange of that information through standardized calls and some routing and orchestration and the like. So here's, let me skip past that. Now I've jumped to some screenshots of Citizen. And so let's take the example, and this tends to be the majority of the patients who come to an HIE or are directed to an HIE to get their own records. They don't have a PHA and they decide, yeah, sure, I'll try a PHA. So I want to take you through the steps that are the identity proofing. I think this will be of interest. So they get to a screen. We tell them what they're going to have to do. We warn them ahead, you're going to need a government ID, and we're going to need your consent to query and such. So we come in, we get their first name, last name, date of birth. And then we get an email address as well. We need to be able to two-factor authenticate them. We have to make sure that we can reach them by one of the methods. So we collect this information. Then they get to a question, do they want to have the Citizen PHA, or do they just want a temporary account so they can download their record? So in one case, they're going to actually end up with a Citizen account. In another case, they're going to have a temporary Citizen account until their data is downloaded in a PDF. We have to get consent, and all the HIEs want to make sure that we've gotten consent to put a query out to our HIEs. So we give them warning, ask for them to, in fact, nod, yes, you can go search my records. We also tell them you might get back, mental health information stuff that, possibly it's disturbing to you to see your own mental health records. So we need to give them fair warning about some things. And then here we get to the identity proofing part. We say you're going to need a government issued ID. And this is a little old. We actually have 3 or 4 more ways, different types of IDs and such that they can use. But for now, it's a state driver's license or a passport in this screen. They get their mobile number. Then we send that mobile number a code, again, TFA. Ask them what government they're working with. They could be, this can work in many countries. This one's shown the United States. If it's the United States, they can use a passport or a driver's license. Again, there's actually more opportunities than just these 2 IDs that they can use now. I'll take a pause there. We did not invent or write or build the identity proofing steps that we're about to go through here, or that we're kind of going through. This is a third party. We've jumped to a third party called Persona. I'm sure many of you have heard of ID.me and Clear, IDEMIA, Experian. There's a number of services that will do NIST level 2 identity proofing. We happen to use Persona. So they have to scan a driver's license. They upload a photo of it. We allow them to easily switch to a phone because sometimes it's hard to do this stuff on your laptop. Maybe you don't have a good camera and so on. So they'll get a QR code or something. They can switch and start doing all of this on the phone. So they can take a picture of their ID and upload it, or they can do their own selfie that you'll see in a minute here. So that's upload. This is blurry, but normally it's got to be a very good photograph or the algorithms won't work. Front and back. And then the last step is that it's going to do liveness and binding to make sure that you're not simply holding up a photograph of somebody in front of the screen. So it's going to ask you to move your head, look left, look right. All that works. And your ID has been proven to be authentic and such. You're now identity proof to NIST level 2. And we go ahead and query that entire HIE network that we have. I want to be clear, that picture I put up before were all the HIEs in the nation. Not all the HIEs we're connected to. Thus far, we're connected to 17 HIEs. Hopefully in a year or two, I can tell you, yeah, we got everybody on there. We created their account. It comes back. It says, hey, we're retrieving your records. Please wait. And then, lo and behold, you get your records. So what does this mean? What's the point? So we've helped HIEs solve a problem, which is to meet the 21st Century Cures Act. But what have we done for the patient? And what can we do for the patient? Well, what do we want? What can we end up with? Well, our goal is that tens of millions of patients will end up with copies of their own record. We want that record not only to be human readable so that they can read through it, they can understand what they're seeing, they can share it with loved ones if they're sick, and things like that. But we also want it in a computable format. We want it as best we can in a research grade computable format for the patient. And then we'd like a marketplace for the patient. We're all familiar with some of these, but patients in the past, patients have had to go to try together with their doctor to find clinical trials that might help them. If you're talking very sick cancer patients, there's significant amounts of inclusion and exclusion criteria to be a participant in a variety of trials. They need to know things like, what lines of therapy have you already done? Have you done chemotherapy? What stage are you? What's your tumor status? Things like that. And you may or may not match. And it's very difficult to wade through that. Well, we would like a marketplace where the primary investigators of those trials are finding the patients that match them because they can. We have a site where patients with those conditions are there, and it can be a matter of milliseconds to know whether or not a patient matches the criteria for your clinical trial, if they're in your region, and if they could participate in that. We also want patients to be able to get second opinions. We want them to be able to participate in precision medicine. We want them, if they want, to be able to sell their data to pharma. As it stands right now, many institutions are packaging up anonymized data and selling it for lots of money without the consent of the patient because it's been anonymized, and getting millions and millions of dollars for that. Meanwhile, the patient is still not benefiting in any way from that. Well, if there's a marketplace where the patients can securely sell their own data, they should be the ones who benefit from that the most. And that's partially where we're trying to go. We'd like to see a paradigm shift where right now the custodians of the medical records are typically your doctor. But that doesn't make sense. You might have many doctors, so you've got a fragmented system. The best possible place would be for a patient to have their full medical record and easily have that all the time and be able to share it with any doctors that they encounter. If patients have a full, robust, computable medical record, we can start the shift from reactive health and medicine to proactive health and medicine. They can start doing and understanding the things that they should be doing, which has been the goal for a long time, but I don't see any way for that to happen without the patient being involved and being at the center of that. And then lastly, going forward, it's already happening, but we fully believe that machine learning and artificial intelligence will be able to compare an individual's situation instantly with thousands of patients who've been on that journey before with some of the same variations, and can provide instantly pathways that had better outcomes than others. And so we're looking to get there as well. So with that, I'll stop. I know that this is with Hyperledger and blockchain, I didn't mention it here, but of course, a marketplace like this where patients can easily sell their records and retain control, it's going to require some of these kind of technologies that secure and track the ownership of those. Maybe we're going to require smart contracts that do the same. So anyway, I'll stop there.
Excellent. Excellent. Thank you. Yeah, I think there's, and it'd be interesting to know, you had mentioned in sort of planning for this discussion that you had started to noodle on how do verifiable credentials and other blockchain concepts fit into this. And I think, you know, in walking through this pipeline with you, sorry, there's a visitor at my office. Dog has to announce them. In walking through this, some of the areas that we've talked about in other, you know, in other contexts, but similar, are first around that identity verification, right? And if you have a verifiable identity credential, you know, sort of using that instead of having to do this, like, okay, I've done it again, now I have to do it again, but I have a credential and I could just say, look, I'm identity proofed, here's who I am, and binding you, you know, you don't have to keep redoing that. So that's sort of one place. And I wonder if you've spent any time yet exploring that, because you've mentioned a few of those other solutions, some of which are private and have privatized and siloed that data. And there are other ones that have done that in a more sort of let the patient own their identity verifiable credential.
Yeah, I agree. So the first thing that, you know, I mentioned that we use Persona at the moment, but the thing about Persona is that you don't end up creating a Persona account that persists. So we retain within Citizen the fact that this ID and credential was identity proofed and bound to this patient. And then therefore, for as long as that ID is unexpired, that's a valid credential and we can hold that. But other places like ID Me and Clear, you end up with a patient account and they hold on to those things. And so we're exploring potential uses where that process, instead of us just identity proofing the patient in Citizen, we have a process where we can do API calls to potentially existing accounts with ID Me or Clear or so on. We're seeing so much of that with TSA, with vaccinations. In New York State, I believe, for you to renew your driver's license, you end up with an ID Me account. You live there, Kayla. Is that true? I've heard that.
There was some work that was being done around, I think it was ID Me, if I'm not mistaken. And then they actually had to back off on it because of the contracts and agreements with ID Me and the language in those. I'm not sure if that has been resolved yet, but I know that it was started, and then and I think this was even with the IRS, they were going to require ID Me accounts. But because of that language and the sort of privatization of that data, they had to back off from that.
Well, the point I was making is that there are many of these places where patients have created accounts and have accounts. And instead of us taking them through an identity proofing process, regardless of that, we want to start looking into ways that we can, through API calls, utilize those accounts and avoid another identity proofing process. And by the way, avoid that cost if we can do it, because we get charged. It's about $1.50 per patient that we identity proof. So it's not an inexpensive thing as you scale this up. So the ability to utilize that, but as you point out, Kayla, the ability to have that in a way where it's retained and it's retained by the patient, and something can be used that way, we're very excited to get to. I think we are in a transitional period. Obviously, we're trying to get this going, but I do think the sands are shifting underneath us for identity proofing. And I think the utilization of Web3 technologies and distributed ledger stuff will kind of change the way over the next 3 to 5 years how we think about and handle these things. And we're actually looking for direction on that. We have been thinking about it, but we don't necessarily have any solutions.
Go ahead, Ken.
If you can rely on external ID proofing, such as a verifiable credential that either was issued by a government or was already proofed by some other account, it's a tremendous cost savings. Plus the user experience is a lot better if you don't have to start over from scratch. One of the nice things about verifiable credentials as a mechanism is that it allows for logging into your site, for instance, just scanning a QR code. The fact that you have the device, you biometrically authenticate to open the device, you have the credential, and it simplifies login processes for interacting with your site or other sites as well. That allows for that establishment of a secure, mutually authenticated connection. It allows for not only you proving that the patient has identified themselves correctly, but if you have a mutually authenticated connection, the patient can also validate that you are indeed the correct site, that they're not talking to a phishing site to try to obtain access to their data or something.
Yeah, that's exactly solutions, kind of solutions we're looking for. We're also looking for I'll call them slightly less high-tech solutions where the patient has just been identity proofed in person. So think of an example where you go to a pharmacy to pick up your medication and they ask you your questions, or they ask for your license or your data, whatever, but you're personally been identity proofed. So we're thinking about ways like, okay, is there a way that there can be a QR code that they can scan right at that time, or barcode that comes on the pharmacy bag that they just handed you, to allow a patient to be, if you will, identity proofed at that point and not have to go through those steps. Again, for us, it has to be accepted and acceptable to the organizations. So, it would have to meet the NIST guidelines for that identity proofing and such. But we're looking for ways to make this much more simple and therefore much more expandable throughout the country. Unfortunately, there's plenty of people in the country who don't have a government ID. Certainly think about, most of the people under the age of 16, which is another challenge anyway, but they don't have a driver's license. Most of them don't have a passport. We're looking any way we can to find identity proofing that is inexpensive and kind of ubiquitous.
Yep.
And so piggybacking on that thought, you're absolutely right that you could leverage those things, right? And so to sort of connect the dots between that idea and how it gets leveraged in a verifiable credential method, right, is that you have, it is an ecosystem. So you mentioned something that you have to kind of wait for people to come with you. There's some of that, and building that ecosystem is really important, but you could have trusted issuers, right? Because it's a whole network of trust is really what it comes down to. So you would have those trusted credential issuers, and they could be issuing an identity credential that they're doing in person, but because you've allowed them into your network and your ecosystem as a trusted issuer of those identity credentials, because they've been trained on what it means to certify to IAL2, then once they've done that, they could offer the person / patient, right, a QR code to scan to sort of accept their identity credential that they can then reuse with other agencies like Citizen or other apps to say, look, I've been identity proofed and it came from, I'm just going to say Hospital A. Hospital A, in your network, and you trust them as an identity verifier to issue those identity credentials. And so that's a way to bridge the gap between the technical heavy solution and the low tech solution, where you put that burden of the tech on the hospital system or the other sort of on ramp into the network to be able to bridge that, and they're able to issue the digital credential.
Right. There is a group I know you're familiar with, the Cantara initiative that certifies NIST IAL2 identity providers. So they're the ones who, verify that persona takes all the steps necessary to do NIST IAL2, and they might be a perfect group, for example, so that we don't have to do it, that can enter in additional ways of trust, and these other organizations that could do that.
Absolutely. Absolutely. And some of the, I'm sort of interested in understanding for the larger group to get a sense of where is the health data housed in these, if you don't mind getting into that just a little bit in this scenario. So you've gone through this process, you do that federated like finding of the data, and then what is happening with the data at that point? If you could just take a second and describe that, I think that would help.
I'll let Jeff talk for a minute.
I say, yeah, I can grab that one. So, the data is in the HIEs to begin with, right? That's the source of data for us, essentially. It passes through the Cures Gateway to the PHAs. So whether that be Citizen or a different PHA, they're the ones that actually have the retention of that data. So the Cures Gateway doesn't retain it, except for like the 7-day thing for those temporary accounts. For a temporary Citizen account, we keep it for about a week. But other than that, I mean, it's just, in and out, and there's no retention of the data in the gateway itself. But yeah, Citizen will, retain the data for their patients, our patients, who are using that app, then they'll retain
Your
that.
PHA.
Yes, from our PHA.
Right, because then they're, sorry.
What do you do with fund data like PACS data?
Well, that's a great question. Go on, Jeff.
I was gonna say it's a really good question. I mean, so right now, we're not getting PACS data through the Cures Gateway. If we want to expand it out and get more of those things, right now, mostly what we're getting is CCD data. So kind of, I'm not sure how much that term means things, but big XML documents, without with a fair amount of encoded data in there. But yeah, we really want to be able to eventually expand this out, and a lot of HIEs have data in HL7 or even PDF or various imaging technologies, and we'd love to be able to get that stuff in. That's where a lot of the detailed meat of the stuff that we want for cancer patients is, like in those like chart notes is where you'll get the details about like how big a tumor is and things like that, that you really need for clinical trial matching. So
to explain that a little further, we do get PACS data when we have cancer patients and we are building their research grade computable medical record. We reach out. So what Jeff was saying is we don't yet get it through the HIEs, but we have other ways that we get data for patients directly from some of their PACS systems. We do support importing of images. The Citizen platform will hold and display PACS images and such. And that takes me to the next point that Keela was asking, which is, so as we ingest the data, particularly through the Cures Gateway, but really through any of the methods that we get data, we're putting that away in a Fire native repository currently. So that this is for Citizen patients. Again, we don't control what third-party PHAs do with the data. We do ensure that they follow the Karen Code of Conduct. I don't know if that means anything to anyone, but those are, pretty kind of strict rules. The good housekeeping seal of approval, if you will, for businesses and what they do with the data. We require, as I said, NIST level 2 identity proofing. We require that they don't do anything with the data without the patient's consent and stuff like that. But they can, how they store the data, we have no say over, and
Right.
so on. But
ultimately, their terms and conditions are whatever the patient chooses to accept.
That's exactly right, because the bottom line 21st century cures and info blocking rules are the patient gets to choose. Even if they choose poorly, they get to choose. It's a bit of a buyer beware, but so we validate that they won't harm the network, these PHAs, and we validate that they're not a Trojan horse, like a ambulance chasing lawyer with the PHA front end and stuff like that. But otherwise, we can't deny that application from participating on the network, and we don't. But I was getting at that we store the data now into a Fire native repository. as I mentioned, it would be nice when we get to a real marketplace of that in fact it was kind of distributed ledger technology, and so that the ownership and use of that data was tracked and controlled. We don't really have extensive capabilities in that right now. So we'd like to have more of those.
Excellent. Yeah, it's a little tricky. And I don't know how much you've worked in this space, right? And so the solutions that we've been building at Cardea have the data reside with the person. So the data lives on their device, but the metadata, let's say for lack of the proper verifiable credential language here, the metadata about that is what goes to the ledger, right? So the who issued it, information so that it can be verified as authentic. That's what's getting written to the ledger itself, so that whoever then wants to consume that data, or in this case, sort of verify in the terms of our trust triangle here, verifying that health data, or in this case, the patient chooses to share it with their second opinion doctor or whomever, that doctor can authenticate and verify its source as being valid and trustworthy, and that it's legitimate. Maybe it's that, it's in theory, it's that you guys could say you had it written to the ledger, right? Citizen issued this. And because of Citizen's upstream procedures, sort of you become the derivative verifiable seal of approval on that. Or it's that the health agencies themselves are writing that, issuing that credential, and that's what can get written to the ledger. And Ken, do you want to correct anything I've said on my?
No, I just want to add a little bit to it, that
Okay.
the verifiable credentials can be used for data transmittal of the patient health record, as Keela has described, or it can be simply used to identify the patient. You can just say, here's your patient identification for medical purposes or for whatever purposes you want to use it for, but it can be used to help identify patients, to have them log into the system, provide consent, make sure that when you download patient records to them in a PDF format or whatever, that you're sending it to the right person, that the patient is talking to the right doctor, it's not a scammer, that when you're consenting to share your data to a research institution, that you're correctly identifying the parties that have signed the waivers or the agreements to allow for the transfer of data. So whether the data is held by the patient or simply the patient identification is held there, and the identifications of the institutions participating, those are the areas that are, I think, interesting and applicable here. You could, you can't really download onto my mobile phone all of the health records, especially if the patient has large numbers of images or
Right.
any size of images, right? That's a very difficult thing to do. But having access control be controlled by those secured, this compatible patient identification credentials helps make the system flow more smoothly and improve the user experience for establishing the connections and working with the different organizations who are participating.
When we've reached that level, right, the next thing we're thinking about, of course, are I guess smart contracts or things, because you want the patient to be able to say, yeah, I'd like to participate in the marketplace. I would like any of these 4 groups to be able to utilize my diabetic healthcare information data, but no, they can't have access to my mental health data or something like that. So and it would be great if they could just indicate that, and then the system ensured that that's all that was available to those participants. And so ultimately we would like to get to that level of granularity and have that essentially automatic, just based on the choices that the patient's able to choose.
Yeah, whether data is stored on my phone or at the HIE or at Citizen, the establishment of the identity and then the ability to provide consent or to access to controls to standard database or access control for transmittal of data to a research institution. All of those things make the experience more reliable because you're acting on excellent credentials to be the basis of the parties involved in the transaction, plus the ability to sign the transactions, whether or not those are smart contracts or just consent forms signed by a patient using their app or whatever to provide the record of what what transactions have been approved and are part of the system. So I think there's a number of ways that digital identity can help. In some cases, it might be still useful to transmit the bulk of the records of the analytical parts, not maybe the images, onto the patient's own device so they can share it with whoever they want to. But I think one of the key benefits is establishing of identity inside the system.
That totally makes sense. And I think that there's, being able to have that identity persist throughout the relationship is one of the kind of key things we see, because, yes, having bulk data anonymized for a pharma company is useful, but what's really useful is being able to say, okay, this is who this patient is for. And if you have follow-up questions, we've seen a lot of things where like a pharma company would be like, okay, we've got the clinical records for all these patients, but now we want to push a questionnaire out to them and say, hey, let's give these patients something to say like, hey, answer some questions for us about like, what has your experience been like? We did a whole COVID study on like how many vaccinations have you taken of which ones and how does that impact your cancer treatment? So being able to like ensure that you've got the right identity for those two-way communications and continual follow-ups on the data is really important too.
And that relationship that's established between the two organizations, the research institute and the patient, and then the ability to communicate between them over a secure encrypted channel gives a lot of assurance that they are talking to the right patient, that the patient's disclosing information if they wish to over that survey or whatever, and they know they're giving it to the right organization. It's not some third party trying to weasel their way into the patient's life and discover things about them. So I think that is that relationship, that permanent connection that allows for messaging to be pushed from either side. It's not a simple client server relationship. It's a peer-to-peer relationship so that either side can initiate a question or a transmittal of a message to the other side.
Yep. Yeah, that's great, Ken. All right, keeping an eye on the clock. I guess the question is, Glenn or Jeff, is there anything else that you want to get to say or ask while we're here? Or maybe there's questions from the group for you guys, but I'll start with Glenn and Jeff for sort of last word.
I did a lot of talking, so I think I've had my words. Jeff, I don't know if you have any.
I can't think of anything that I really want to add to this. I think, it's a lot of this stuff is very new for us, and we're kind of at the very beginning of getting a lot of these things in place. So it's great to have like a group that we can potentially bounce some ideas off of. So, Keela, thanks for setting this up and reaching out about this. I think that, that's something that I expect we'll be talking more in the future.
You're welcome to come every second and fourth Thursday of the month. We meet here, slightly different Zoom links, as we've discussed. Are there any questions from any of our participants who would like to speak up now? Or you can throw them in the chat.
This is Adrian. I have a quick question. I looked up Cardea and it was all about the Aruba experiment. Yet this was not mentioned at all in this context today. And I'm curious what, what's the overlap, or where did I click errantly?
You didn't click errantly. You are in the right place. This is the Cardea working group. The Aruba implementation using verifiable credentials was one of our pilot projects, which now is some time ago. And it's certainly sort of leapfrogged us into developing, in conjunction with CETA, the agents that create the Cardea network, and it was the first implemented use case for the toolkit that we have in the Cardea sort of toolbox. But we're talking about, because the Cardea, because of the COVID specific use case kind of fading from relevance as the priority for us, we've started to pay attention to what other spaces Cardea might be applicable to. And so we've had a series of guest speakers coming in talking about sort of their health, either focused or tangential needs, and how we might bridge those with the Cardea agents. So if you want to talk more about Aruba specifically and how that was implemented and some of the details there, Adrian, Ken, or I, or both of us, would be happy to loop you in or answer any questions related to that.
Oh, no, thank you. That's clear. And this was a really good master class in HIE. I appreciate that you put this on.
Excellent. Happy to have done that. And welcome, Adrian.
Good to hear your voice. It's been quite a while since I've bumped into you, Adrian, but welcome. We're glad to have you here.
Thank you.
Excellent. Okay. Well, with that, thank you both, Glenn and Jeff, for your time today. You already got one compliment from Adrian, so that's excellent. This recording will be available on the Hyperledger website, and their YouTube, I think, is where it ends up. And we'll be meeting again in 2 weeks from now. So thank you all.
Thank you. It was our pleasure.
Have a great day, everybody.
Thank you. Bye-bye.